Hello, I'm Dr. David Hornbrook. I think one of the most difficult and confusing things about dentistry is the subject of occlusion. I think we had a good education in occlusion in dental school, but it wasn't practical. When our patients sit down in our chair and we see occlusal disease or pathology, where do we go from that? And what can we do to not only provide our patient, I think, with better restorative dentistry, but to eliminate future problems with maybe dentistry that we place? Every day we see cases such as this, where there's a tremendous amount of wear, a tremendous amount of pathology, and either we want to meet our patient's needs or they're confused or concerned about what's going on in their own mouth. You take a case like this. Young woman, 45 years old. Look at the amount of pathology. What do we do with a case like this, whether it be restorative or whether it be cosmetic? 40 years old, attractive, doesn't like her smile, and she comes into your practice and says, "Hey doc, I want a nicer smile." How do we address this? Do we just slap on 10 veneers or 20 veneers and hope that they work? How many of you have had increased failures because you put so much glass because you didn't really understand how the bite relationship was supposed to be designed to yield the longest prognosis and the best results?
I do a wax up, I mock it all up, I make this smile design look like the final case. And then the patient and I decide, is this something that we want, or do we need to change things? With these prepless veneers on this minimal or this moderate communication, I treat it almost like as if I'm doing a wax rim and the ceramist is now setting denture teeth. So you imagine, what information does your denture fabricator need to put teeth in your wax rim? I need the length of centrals. So I take a flowable resin, I mock it up. I'm going to make a smile line. Again, think of your wax rim. I'm going to make sure my incisal edge of my mock-up, and I use a flowable resin, is parallel to my interpupillary line. I designed my facial profile, and I think this is so important, especially on these post-ortho cases where there was extractions. I'll build resin on from the facial, and I'll constantly looking from the profile, taking back a little bit if I need to, adding to if I want to upright that. Buccal corridor. If I bring out the buccal corridor, again on these post-orthodontic cases, I almost always have to bring them out. Instead of just saying, bring out the buccal corridor, I take a flowable resin and I bring them out, having the patient smile, they're not numb, and deciding, I need to bring it out a little bit more, or bring it in, or this side needs to come out more. And then lastly, midline. Again, think of your wax rim with dentures. After you get the incisal edge, you get the contours, you get your buccal corridor, take down that wax, then we take a scribe and we make a line where the midline is.